Hi, my name is Wanda Paulson, the Advanced Care Planning Program Manager at Essentia. I want to thank you so much for joining me today to take some time to learn about advanced care planning and out of hospital resuscitation orders. We want to share with you about the work we are doing at Essentia to promote person centered care and how we can partner with those in their communities to honor patients' wishes. Today's presentation will include information from Honoring Choices Minnesota, Respecting Choices, POLST Minnesota, and I'll also be sharing some information from Ariadne Labs. In our time together today, we will discuss the terms advanced care planning, advanced directive, and healthcare agent. We'll compare advanced directives and out of hospital resuscitation orders, including POLST and the Wisconsin DNR. We'll reflect on how advanced care planning is important for all adults, even you, and discuss how this promotes person-centered care. Advanced care planning helps to incorporate an individual's goals, values, and belief, what matters most to each person, into the care we provide. This person-centered approach to care includes ongoing conversation with patients throughout the continuum of care. It's not a one-time event, but rather a process over time as a patient's wishes may change as circumstances change. Advanced care planning allows an individual's wishes regarding life-sustaining treatments to be known, communicated, and honored across health settings. Advanced care planning is a process for planning for future healthcare decisions. It's really important to know that advanced care planning is not just for the elderly or the very sick. Advanced care planning is important for every adult age 18 and over, not just someone we think something might happen to or those we consider to be high risk. As my grandma always used to say, you just never know what a day can bring. If wishes are not expressed, decisions are made for us, and those decisions may not align with our choices or values. And families and healthcare providers are left wondering what to do and if they made the right choice. This causes family and healthcare teams stress and burden. Advanced care planning is for everyone, but individuals who have serious illness feel especially vulnerable and can feel some uncertainty and fears regarding their health and underlying health issues. Although we cannot eliminate the uncertainty about whether someone will get sick or experience a significant decline in their health, having proactive conversations about the kind of care someone wants or maybe does not want should they become severely ill will help limit that uncertainty. One of the most important decisions we encourage all adults to make is choosing someone now to make healthcare decisions for you in the future if you were unable to speak for yourself. A healthcare agent is a type of surrogate decision maker who has the legal authority to make healthcare decisions on behalf of an individual when that person is unable to make and communicate decisions. A healthcare agent is sometimes referred to the healthcare power of attorney, but it's important to note that this is not the same as a power of attorney that deals with financial matters. There are some important qualities to look for in a healthcare agent. First of all, it's important to make sure they are willing. While family or spouse may seem like a natural choice, it's important to talk with them about that role. Some people actually choose not to have family as their agents. Whoever you choose, it's important to choose someone who you trust to speak on your behalf. It's also important to choose someone who is willing to talk with you about your goals, values, and preferences. And again, whoever you choose, it's important to communicate with them so that they know your current wishes and any changes to your wishes as life circumstances change. It's also very important to choose someone who can agree to honor your wishes, even if they are different from their own. They have to understand that they are speaking for you, not for themselves. And lastly, your agent should be someone who is willing and able to make decisions during difficult or emotional situations. The more you share with your agent and other family members, the less stress, confusion, or potential conflict your loved ones are likely to face. It's important to tell other family members who your agent is so there are no surprises and they can be supportive of your agent whenever they are called upon to serve in that role. And it's important to choose an alternate or two. Advanced care planning is much more than completing some paperwork. At Essentia, we encourage providers to especially have proactive conversations with patients who have serious or life limiting illness to help guide treatment decisions. Many things can impact the way we make decisions. Our life experiences shape us, and it's important to reflect on what impacts our decisions. When I meet with patients, part of the conversation includes talking about any past experience someone has had with loved ones or someone close to them who is very ill or dying. For many people, the loss of a loved one or the fear and uncertainty they may have about their own health or illness can really impact the kind of care they want or maybe don't want. In addition to our past experiences, it's also helpful to think about the activities we engage in that are important to us and that give our life meaning. The things that give life meaning are very individualized and may change over time. There are differences among people. What is acceptable to one person may not be acceptable to another. As we think about things like what a good day looks like or what's important to us to live well, we want people to reflect on what brings meaning to their life and makes life most worth living, and how that may relate to some of their wishes for future care. On the Minnesota Honoring Choices Healthcare Directive, there are some important questions for people to consider, such as the things that make life most worth living are, or my beliefs about when life would no longer be worth living. These important questions help people to really think about what matters most to them and what things would be acceptable for their care or maybe no longer acceptable. Just as our past experiences shape us, it's also important to reflect on any spiritual, religious, or personal beliefs that might impact the care someone would want. For our providers, we have recommended the use of Ariadne Labs' Serious Illness Conversation Guide for their conversations with patients with chronic or serious illness. We believe that compassionate, person centered care begins with communication. Prior to filling out a healthcare directive or provider orders, the conversation is very important. For our patients with serious illness, there are several key themes we want to ensure we are understanding. I want to share just a few of these questions that are typically covered in this type of conversation. As I read them, I want you to put yourself in the shoes of a patient and think how you would answer each of these questions if you were the person having a conversation with a healthcare provider. For example, what are your most important goals if your health situation worsens? What are your biggest fears and worries about the future with your health? What gives you strength as you think about the future with your illness? What abilities are so critical to your life that you can't imagine living without them? If you become sicker, how much are you willing to go through for the possibility of gaining more time? And lastly, how much does your family know about your priorities and wishes? The goal in this conversation is get to the heart of what matters most to each person and what their goals are for their care, and this will help guide treatment choices. When I meet with patients, I try to get an understanding of their overall goals. For example, are they expressing a desire to live as long as possible, no matter what? Or is this person sharing that their goal is to avoid aggressive medical treatments and to focus more on comfort? In addition to some of those overall goals and themes, we do want patients to think about some treatment decisions in some key areas, especially during this time of COVID-19. We can't possibly think of every medical situation that might come up or every decision that might need to be made, but it's helpful to think about some goals for some key areas before a crisis occurs. For example, if a patient's condition worsens or if they were to contract a serious illness like COVID-19, what would their goals be for hospitalization? Would they want to be hospitalized or would they prefer treatment at home? What is their understanding of oxygen support or mechanical ventilation? Do they want CPR? What is their understanding of medicine and supportive care? Honoring Choices Minnesota has some excellent resources for patients, but I want to specifically point out this COVID-19 guide that can be found on the Honoring Choices website. This form helps patients think about and talk about their wishes if they were to contract COVID-19, but it is a very nice tool for people to think about their goals if they were to become otherwise seriously ill. The outcome of effective advanced care planning conversations is ideally the development of a healthcare directive or advance directive. This is a legal written document that allows an individual to appoint a healthcare agent and to describe their general healthcare preferences or instructions to serve as a guide for treatment decisions if they were to become seriously ill and hospitalized. All adults are encouraged to complete a healthcare directive for the state in which they reside. Each state has some different statutes or some different requirements for the witness signature. So at Essentia, we recommend Honoring Choices Minnesota, Honoring Choices Wisconsin, and Honoring Choices North Dakota forms for our patients. HonoringChoices.org has a lot of excellent resources for completing an advance directive and some general tools that will be very helpful as you have conversations with patients. For patients who do not want aggressive medical care, a POLST or Wisconsin DNR order may be appropriate. So we're going to spend a little bit of time discussing the out-of-hospital resuscitation orders. First of all, what is POLST? POLST stands for Provider Orders for Life-Sustaining Treatment. The purpose of POLST is to give very ill patients more control over the treatment they do and do not want to receive. POLST forms help to translate general advanced care planning goals into specific medical orders, primarily for patients with serious illness or frailty, whose healthcare provider would not be surprised if they died within a year or two. For example, patients with advanced heart disease, advanced lung disease, or cancer that has spread. POLST forms should be completed after the patient or the patient's surrogate or healthcare agent has talked with the provider or other healthcare professional about the patient's prognosis and diagnosis, the patient's goals of care, and treatment options, including benefits and burdens of each. A POLST form is used to turn a patient's treatment wishes into a medical order. The POLST form moves with the patient so that it can be used in outpatient settings where the patient may receive care, such as at home, assisted living, or a long-term care facility. The POLST form helps reinforce the patient's wishes. In a medical emergency, emergency medical services and volunteer first responders or other healthcare professionals will do everything possible to try to save a person's life. But not all patients who are seriously ill or frail want that type of treatment. The POLST form lets patients define what care they do and do not want to receive. Again, before the POLST form is completed, the patient should have a discussion with their healthcare provider or other healthcare professional. They and their loved one should feel well informed about the health condition, understand how quickly their condition may worsen, know what their treatment options are, and think about what treatment options make sense for them given their personal beliefs, values, and goals. As we've said, a POLST is a medical order, which means it must be signed by a physician, advanced practice registered nurse, or physician assistant to be valid. By signing the form, the healthcare provider indicates that the orders on the form are based on the patient's current medical condition and treatment wishes. Here at Essentia, our policy and procedure indicates that the POLST forms can be completed and signed by a provider as an outcome of a serious illness conversation with the patient or their healthcare agent. These conversations are documented within the medical record and support these orders. Both healthcare directives and POLST forms are types of advanced care plans. They support each other, but they do different things. So to review, all capable adults should have healthcare directives. The healthcare directive is used to identify someone, in other words, the healthcare agent, who can make healthcare decisions in case you are not able to make decisions on your own. A healthcare directive is also used to outline your future healthcare wishes. But in the community, in the event of an emergency, EMS or other healthcare professionals cannot follow the treatment wishes included in the healthcare directive as a medical order. If a person becomes seriously ill, a POLST form can help turn their wishes into a medical order that can be followed in an emergency. A POLST form notes what treatment a person does and does not want to receive. In order to ensure that EMS or other healthcare professionals can follow these wishes, a POLST is required. I just want to compare and contrast these documents just slightly and introduce the Wisconsin DNR order as well. So the healthcare directive is completed by the patient, where they can name an agent and state their wishes for future medical care. In contrast, the Minnesota and North Dakota POLST orders are completed by a provider, and they create orders for emergencies for medical care in the event of cardiopulmonary arrest, but also for when someone is not in an arrest but has another medical emergency. The Wisconsin DNR order is again completed by a provider, but it is only in the case of a cardiopulmonary arrest. It's really important to understand that as long as a patient has the ability to speak for themselves, they can change their mind about their wishes. They have a right to change their mind as long as they can speak, they can do so. These documents are for when a patient is not able to speak for themselves. If a patient does change their mind, new documents should be completed to ensure the patient's current wishes are reflected. If you'd like some more information about healthcare directives and advanced care planning resources, I recommend the Honoring Choices Minnesota website. To just shift gears here to the Wisconsin residents, the POLST is an out-of-hospital resuscitation order that has been adopted in many states, including Minnesota and North Dakota. But in Wisconsin, POLST is not used, but rather there's a separate process and the Wisconsin DNR form is used. Patients who choose not to be resuscitated in the outpatient setting are then given a medical bracelet to wear, which can be honored by EMS. The POLST form does more than the DNR order. Like a DNR order, the POLST lets EMS and other healthcare members know whether the patient wants cardiopulmonary resuscitation or not. A DNR order only applies when the person does not have a pulse, is not breathing, and is unresponsive. However, in most medical emergencies, a person does have a pulse, is breathing, and might be responsive. As we will discuss in the next few slides, a POLST form provides more information to EMS other than whether or not the patient wants CPR. The medical treatment options selected on POLST allows the patient to provide more specific guidance on the care they want, but the DNR form is really specific to resuscitation wishes. This is just a brief overview of the Wisconsin form that can be found at www.dhs.wisconsin.gov if you wanted to see the full form or print off a copy. That would be the best place to look. Here is a copy of the POLST form. In the next slides, we'll specifically focus on sections A and B. For our EMS and first responders working in the community that maybe aren't as familiar with the POLST form, I encourage you to visit POLST Minnesota website. Just to get a closer look at this in the POLST form, provide in section A, this is in regards to someone who is in cardiopulmonary arrest. The choices are either to attempt resuscitation, CPR, and the other choice is do not attempt resuscitation, so DNAR. It's important to note that DNAR does not necessarily mean DNI, do not intubate. Someone could say they do not want to be resuscitated, but they may wish to try intubation for breathing support. When someone is not in cardiopulmonary arrest, you will go to and follow section B. There are 3 medical treatment options on the POLST form in section B. The first option is full treatment. Full treatment means that all medical treatments and care will be used to save a patient's life. For example, full treatment may include the use of CPR, a breathing machine, transfer to the hospital or intensive care unit. Also note that under Section A, if someone chooses attempt resuscitation, the directions state selecting this requires selecting full treatment. The second option in this section is selective treatment. Selective treatment means that the medical treatments and care will be used to make sure a patient does not get sicker or will be used to treat a new problem that occurs. For example, selective treatment may include the use of medications, antibiotics for pneumonia, or heart monitors. More intensive care that may be needed to save the patient's life, such as a breathing machine, will not be used. The patient will be taken to the hospital if needed. The third option is comfort-focused treatment. Comfort-focused treatment means the medical treatments and care will be used to relieve the patient's pain and suffering. For example, the use of medications, wound care, and suction. The patient will not be taken to the hospital for life-sustaining care, but may be taken to the hospital if comfort cannot be provided at the current location. Under Section C, you'll see that the patient or the healthcare agent or surrogate are strongly encouraged to sign the document. A valid POLST requires the signature of a physician, advanced practice registered nurse, or physician assistant to be an actionable order. The POLST form also separately allows patients to choose whether or not they would like artificially administered nutrition and antibiotics. Clearly, if a patient does not have decision-making capacity for this discussion and healthcare decisions, a surrogate needs to be determined. To evaluate capacity, providers must be able to answer yes to the following questions. Can the patient communicate a choice? Can the patient understand the relevant information? Can the patient appreciate the situation and its consequences? Can the patient reason about treatment options? If the patient cannot answer these questions, you must speak to his surrogate to complete the POLST form. Even if a patient has capacity, we really encourage the surrogate, healthcare agent, or family to be present for this conversation. It's really important that the healthcare agent be present for any discussion about goals of care and completion of the advance directive or POLST. What I've heard from one of our hospitalists and members of the ethics committee is that if family has not been involved in the conversation, especially if a patient does not have capacity, there is often dissent and distrust from the excluded family when the POLST is used at the time of crisis. Earlier, I mentioned that at Essentia, we've recommended that providers have shared decision-making conversations with patients using a serious illness conversation guide from Ariadne Labs. Our policy and best practice indicates that POLST forms are only completed as the result of a shared decision-making conversation and documentation in the patient's chart to support this conversation, and then the completion of the out-of-hospital resuscitation orders like POLST or the Wisconsin DNR. I want to stress that an important part of the conversation is sharing prognosis, and the prognosis part of this conversation is really in the scope of a provider. The medical piece of the conversation and decision-making capacity is really key. For those of you working in the community settings, the Minnesota POLST website has a lot of information on the POLST form. There's some frequently asked questions, as well as some guides for completing POLST in assisted living and skilled nursing facilities. Like the Ariadne Serious Lab Conversation Guide that is geared towards providers, Minnesota POLST has some scripting and tools that can be used for those having conversations with patients. There's also a link to a 12-minute video that you could review in having these conversations with patients. In summary, POLST is indicated for those whose healthcare provider would not be surprised if they died within the next year or two. POLST is a portable, meaning it remains active outside of the hospital. Once a patient comes to the emergency room or hospital, the POLST is a guide to inform the discussions about goals of care. It's no longer an active order. POLST is not the same as an advance directive. POLST can only be completed after a shared decision-making conversation. The patient or their surrogate or healthcare agent signature is expected in Minnesota, but it's required in North Dakota. POLST forms should be reviewed and updated periodically to ensure it reflects the patient's current goals of care. POLST forms should be reviewed and updated by completing a new form if there is a change, such as a change in the patient's health condition, a change in their goals, or if their health care setting changes. For example, if they are in a long-term care facility and they're transferred to the hospital or vice versa. A POLST is indicated for patients who we would not be surprised if they died in the next 1 to 2 years. So at a minimum, annual review of the POLST is appropriate. It's really important that wishes are entered into the medical record so the medical team can be aware and be able to honor the patient's wishes. A copy of an advance directive or any out-of-hospital resuscitation order should be shared with any facility that provides care to the patient. At Essentia, we have some ways to make sure that the records are reflecting the patient's wishes. We ask that they be faxed, emailed, or mailed to our medical records department so we can ensure that their current wishes are reflected in their medical record. I want to thank you so much for joining me today to learn more about advanced care planning and how important it is to have these conversations with our patients as we honor their wishes by completing advance directives and the out-of-hospital resuscitation orders. Thank you so much for all you do to help ensure we're honoring patients' wishes both here in the hospital and out in the community. Take care.